Okay, good morning everybody. First of all, I want to say that I am really proud to be a part of such a wonderful team, and I want to thank John Davis for organizing such a great course. My speech is about nurse training RRT. I think all of us, we agree, first of all, doing a good nurse training, we have to know the details of surgical anatomy of prostate and neurovascular bundles. Dr. Myers is among us. It's a great honor for us. In 2010, I strongly recommend everybody to read this article. They did a fantastic job, a very good article about surgical anatomy of prostate and neurovascular bundles. I have learned a lot from this paper, and I will use some of his pictures. And this year, a few months ago, they published the new version of this paper, an update. It's mostly about the differences, if Dr. Myers agree with me, the mild differences between the neurovascular bundles and the nurse training. There are some important differences. If you talk about the prostatic fascias, first we can call levator fascia. It's named in endopelvic fascia in some papers, and in some papers levator fascia, it's the same. Endopelvic fascia has two layers. One of them is covering the levatorani. It's we call parietal endopelvic fascia, and the other one is covering the prostate. It's visceral fascia, and then comes periprostatic fascia. In some literature, you can see in some nomenclature you can see prostatic fascia, and after that you can see prostate capsule. This year, this panel they declared that the prostate capsule should be named as pseudocapsule, because it's not a real capsule. It's condensation of fibromuscular layer and muscle layers. So we have to be careful about that. The prostatic fascia is not always, these fascias are like onion rings. They are not separate rings, layers. So we have to be careful about that. If you look at this publication again, this shows different historical sections of 5 different prostates from 5 different patients. If you look at first A, the prostatic fascia is colored blue and the capsule is colored red. In A, there is no prostatic fascia in the first patient. If you look at A, E, there is a thick prostatic fascia and there is no prostatic capsule in this patient. Between B, C, and D, the prostatic capsule and prostatic fascia are fused to each other. So what I say, it's not easy to see prostatic fascia separately in all of our patients. Sometimes they are fused together. In some operations, so that means we have to make our operations according to these process. We do 3 types of nurse training mostly: extrafascial dissection, interfascial dissection, and intrafascial dissection. You see the yellow line is intrafascial dissection. It's just over the prostate capsule. The green line is interfascial dissection. It leaves periprostatic fascia on the prostate. And this one is extrafascial. It means non-nurse training dissection. But mostly we do interfascial and intrafascial nurse training dissections during our surgeries. What does interfascial mean? Interfascial means you go directly on the prostate capsule. The plane is over the prostate capsule. You leave prostatic fascia inside the patient, and it allows us to preserve whole thickness of neurovascular bundles. This is the highest degree of preserving nerves. But we can make this nurse training only in low-risk patients, because with this nurse training you can have high surgical margin positivity, or at least capsular incision of prostate. You have to be careful. You have to select your patients. And if you look at interfascial dissection, it's between these 2 leaves. You leave prostatic fascia on the prostate, and between this fascia and endopelvic fascia, you have to find prostatic fascia, and this plane is between them. This is a safer approach. This is oncologically. It gives us a safer margin when we do nurse training. Let's see a nurse training, an antegrade nurse training procedure. So I want to ask with the panel. What we should be careful about when we are doing nerve sparing, we should do less traction. We shouldn't use any cautery. What's your opinion today? Good nerve sparing.
Endless debate on that. Certainly, if you can avoid traction, is good. The trade-off that I hear a lot of experts argue about is if you have three choices, you can put a clip, you can do a second of bipolar, or you can do a second of monopolar. And I've heard advocates of all three of those and try to really rectify which one's the least. I certainly think a strong rationale for avoiding clips from that point where you are there forward is to not get clips migrating into your anastomosis, which is virtually the only strictures I've seen in years, is clip migration. I've actually, I don't think in many, many years seen a true blooded stricture like you did in the 90s, so to speak. So yeah, you clip the base, and then from there, if I feel like I'm off the nerve enough and I can pinch something, I'll do a second of bipolar, and I've seen some folks cut, and if something bleeds arterially, they'll take one blade, one needle, and tap it with monopolar. I'm sure all those techniques have their various pro and con. And actually the third, or I guess that'll be fourth option, is just to cut it and let it bleed, and then you chase it with oral Vicryl then and there if it's bothering you, or if it's minor, I usually get the prostate out, and then that was my point on the side of chasing bleeders with oral Vicryl. It's certainly possible, but very expensive to start chasing bleeders with, vascular products, your flow seal, and all that stuff. And many experts would say that Fibrillar and other of those pad-type products break down into an acidic component that is maybe not nerve-friendly.
Kevin?
Who else? Kevin?
So excessive bleeding, in order not to see too much bleeding in our field, do you rise the common peritoneum?
Well, we were just talking about that. I mean, the first thing whenever I start the neurovascular bundle, if there is to be an oozier environment, I will ask the pressure to be raised. I typically use them at 14 millimeters of mercury, and I think bringing it up to 20 for 10-15 minutes would be a nice initial aspect, especially if it's venous, especially when you're coming along here, sometimes you get into those venules that just obscure your view, and then what that brings then is your resident or your medical student in there with the suction or your fellow and putting a lot more traction. So if I can just raise the pressure, and I don't think I've had any significant adverse events in doing so, I think it's a simple little easy maneuver to start with, and if it becomes more difficult, try to maybe spot monopolar for individuals, but try to limit any pottery and traction as much as possible for its impact on those small and myelinated nerves.
And let me clarify, you want a choice, for example, you've seen versions of it in that very video, is if you have to grab and create traction, if you can, do that on the specimen side. Lift up on the prostate, let the nerve passively stretch a little bit. It is still a trade-off. You see Fatih does some motions I call paint stroking, where you kind of do that, blunt, gentle thing. You got to do some of that, but in some cases, if I can see where I want to go, I'd rather pinch anatomy very briefly and sharply cut it down, and I think that's less stress injury. But this is all visual judgment, and hard to really know.
And I want to ask again, what do you think about this type of nerve sparing? It was an intrafascial nerve sparing or intact? Do you think it? Do you want to see the specimen? Mm-hmm. Okay. Let's see the specimen. This is the specimen of this paper. So, yeah, this is intra.
What would Dr. Myers think? This inter versus intra, it's really become something in the robot era when people think they see things better, but this is intra.
This is intrafascial. You can see it from the prostate, the capsule very easily. It's shining. There is no tissue left on the prostate capsule. And this was the previous patient's video. You can see. But we can do this nerve sparing only in low risk patients, and this patient had low risk and with negative surgery.
A quick comment, because your pathologist will give you interesting feedback, especially if you were posterior lateral and do that dissection. If you have a positive margin, usually my pathologist will continue on and say there is no extra prostatic tissue in which to judge if there is T3 staging. It's just bare. The opposite comment you'll get is it's more correlated with more superior nerve involvement, is you'll actually have a full nerve sparing. You will get a negative surgical margin with a T3 stage, just because there can be a little rim of microscopic fat, especially up high. If it's got tumor-touching fat, they're going to call that extraprostatic extension. It always amazed me when I first started practice and studying. I was like, how did I get a T3 cancer with a clear margin? Yeah, and sometimes with a negative MR saying it was T3.
Okay, how about incremental nerve sparing? This is a hot topic during the last 3 or 4 years. What does it mean? In case of low-risk prostate cancer and low-risk extraprostatic extension, especially in T2 tumors, we do a closer dissection. It means we stay very close to prostate capsule. But in cases of high risk of extension in high-risk patients, we have to select a wider dissection plane. This approach is named incremental nerve sparing. And if you look at the literature and other publications, how much we preserve the nerves, there is low safety margin to avoid positive surgical margin. How much we do a poor nerve sparing, there is high safety margins. So we have to do both. Sometimes at the same patient, we may choose intrafascial dissection on one side and interfascial dissection on 2 sides, especially in normal patients. You see, this part is intrafascial dissection at the same patient. This is inter. The biopsies were positive on this side, on right side. It's reverse side. And the MRI found a tumor on right side, nothing on left side. So sometimes especially in young patients, when I want to preserve as much as possible nerves, I do intrafascial dissection on one side and interfascial dissection on another side. It's possible, but as you remember, these are not distinct layers. You see, this is a very loose tissue. There is no separate prostatic fascia in all patients. You can see this, but you will leave a little tissue margin on high-risk side. So a few years ago, Ashtavari, he described incremental nerve sparing in 4 grades. What are these grades? The key landmark is for Ashtavari is the veins on the prostate. If you look at here, he divided 4 grades. Grade 1 is dissection below the veins. You see, there's only prostate capsule in the specimen. Grade 2, dissection over the veins, on the veins. So there's prostate capsule and venous tissues, veins, and dissection distant from the veins. Level 3, you see the veins and prostate here. And 4 is extrafascial dissection. I think this is very hard to replicate. As you all know, during the nerve sparing, the veins bleed easily. It's very hard to select a plane between the vein and prostate capsule and between the vein and periprostatic fascia. To my opinion, experience, the vein bleed a lot. It will play. After that, a few years, what I described, he took landmark of K artery landmark and he made something different. He divided 5 degrees and starting from not 1, starting from 5. This is blood dissection below the arteries. And you see there's only prostate capsule and 1 is extrafascial dissection, no nerve sparing. If you look at his publication, in all of these cases, you have to find the landmark artery. And then you should do your nerve sparing according to your landmark artery. But the difference between Tevari and Patel, Tevari is doing antegrade nerve sparing, Patel is doing retrograde mostly. So when you do retrograde nerve sparing, you have to find the landmark artery on all of your cases. If you spare landmark artery in grade 5, you will protect 95% of all nerves. Then, in this case, and second, fourth, you will spare 75, protect 50, less than 50, no nerve sparing.
Can I just do a quick show of hands? How many people have convinced themselves they have found the landmark artery in the middle of the section? Who's looked for it? This is hard, so it's hard to find. Or who's never heard of it? You've never heard of this? No? I find it sometimes by accident. Oh, there it is. Cool. You know, but I don't always find it. I don't know if I'm missing it or if it's buried, but I think it is there.
I found it usually as I cut it and make it bleed. But every time you see it,
you could only find it 70% of the time.
I've not heard that stat, but that makes sense, because sometimes I'm like, I know I'm as close as humanly possible, and I don't see
I would say
anything
in a few
remarkable.
minutes,
But
they found only 73%.
Good.
So,
but all of these Tuari and Patel, these nice papers you refer to, they're very useful because they are showing us, let's work very hard on trying to identify the landmarks in these cases. And normal humans like us may not always see these beautiful planes that you see described in these papers, but I think the principles of being extremely meticulous about understanding am I in an interfascial plane or intrafascial, where you might want to be, and do these landmark arteries help are very useful things to have all the time. Obsess about your anatomical approach.
so this is the technique. This is one of my videos that I did a retrograde nerve sparing. I think it's not easy to find the landmark artery in all of your cases, but again, you can find the white tissue when you are in the right plane. I will show it in a minute. Yes. This is the right plane. If you see a curly white tissue in your between the prostate and the bundles, that means you are in a correct plane. So I think this is a very good option if you want to make an interfascial nerve sparing in intermediate risk patients, and this is a very good option. You come back, and this is the pedicle, the clipper. At the same patient, if you look at on the left side, sometimes I come high to preserve the anterolateral nerves. Do you agree with me, Beckman?
Yes,
At the same patient, sometimes even I do retrograde.
So this question is about how high up anteriorly on the prostate you might want to start your interfascial or whatever nerve sparing plan. We've published a couple of papers about this, myself and Tony Costello. And what we were provoked to do our most recent paper in the BJUI a couple of years ago because we had these reports saying these anterior layers were full of nerves and we had to preserve all these layers like a veil of Aphrodite type thing. And what we showed in our subsequent very selective staining on our cadaveric population was that there are nerves anteriorly, but they're predominantly sympathetic nerves, not functionally relevant for erectile function. And what we demonstrated was that the vast majority of the parasympathetic nerves were in the posterolateral, the classic Walsh-Myers sort of distribution. And I think, therefore, there's no point preserving all the anterior stuff, but we do like to open above the horizon position because it means you're not coming straight in onto the nerve bundle. You have a little bit of leaf of fascia to deal with, less traction perhaps. So we do exactly like you, Fatih, but I think it's important to know that the functionally relevant nerves are, I believe, in the classic posterolateral position.
Okay. In my patients, sometimes if I do both sides retrograde, on one side I try to spare posterolateral located nerves, and on the other side I do a little bit, like not too much closer, but like high anterior release. In this patient, I preserved on retrograde on right side, and on left side I did a little bit higher nerve sparing release. So after the surgery, it looks like this patient. Okay, let's see if we were discussing a few minutes ago with Dr. Myers, if it's possible, if we can see the landmark artery in all patients. It's not easy. We can see landmark artery in all of our patients, in all our cases. You see the landmark artery is seen here. This is the landmark artery. This is the pedicle. So, but it's not replicable in all cases. With Patel, he published his results. He first described this technique. He found only 73%. That means in 27%, and nearly in a roughly say, we can 30% of patients he couldn't find the landmark artery. So this technique is not easy. It's not replicable easily, especially in early learning curve. My second point for retrograde nerve release is if if you look at the publications, they said that if you do a grade 5, highest nurse failure, you can protect 95% of all nurses. But how about the periprostatic nerve distribution? If you look at it closer, in some publications, for example, Gazer et al., he found that 20% of these nerves are not only in posterolateral side, they are in anterolateral side. And another publication, these are 3D views of 74-year-old man. If you look at another publication, at the apex, at the base you have 20%, but when you come to closer to apex and urethra, you will see that here, it's sometimes 40% of these nerves are turning anterolateral side. So if you want to have a complete nurse failure, do we have to make a high anterior release, John?
I definitely tried it, and there's an emerging body of literature that supports that helping incontinence. It's a totally different anatomy.
If you say that helping incontinence, yes. Do they improve erectile function and helping incontinence?
Well,
there are publications.
Erectile function is probably low, and incontinence is probably high. Is some of the papers I've seen.
So we wrote a letter to the editor after the Alsay paper, disagreeing with it. And I was a reviewer on the paper, and the pictures are very nice, but this is not a very nurse immunohistochemistry study. It's mostly computer-generated hypothesis, really. So we pointed that out in the letter to the editor. It's nice work. I'm not sure any of the authors here, but it really, we fundamentally disagree with that statement, actually, that about parasympathetic
But there are publications with, for example, Gazer et al. It's in immunohistochemistry.
I agree, and the whole series of talks about that, but our paper in the BJY 2011 is the only one that really correctly stained that there was synthetic parasympathetic. But we can argue the toss on that, but I think the point about the nerves changing at the apex is very important, although and we showed this in our paper as well, we step section, base, mid, apex, you could see the distribution was changing as you went distally. And the nerves all start out at the base and they do rise up. So I think that's why the apex is extremely important, and preserving anterior structures at the apex is very important. The comment about continence, we published a systematic review in European Urology a few months ago, looking at this whole role, this question of does the nerve sparing help continence, and our meta-analysis, a systematic review, had two observations. First of all, of course, the quality of the data is very poor, so that directly informs your meta-analysis. But second, the data does suggest that nerve sparing may improve early continence, but in all our forest plots, it made no difference at 6 months whether you spared nerves or not in terms of continence. And I think that's more about the fascia dissection, not the nerves.
Okay, to my personal opinion, I believe in low risk patients, very low risk patients. Sometimes you have active surveillance patients, they decide their minds and they want to undergo surgery. I do high anterior release to these patients. I don't know, Kevin or Rob, do you do high anterior release? And with high anterior release, we have better continence and erectile function in these patients. This is my opinion.
I mean, to plan out, I normally would say based on the number of cores, the palpability of the tumor, the PSA, based on the nomograms, we'll kind of individualize the size of the treatment of a very young person. I'll always try, especially if I can do a retrograde, it's kind of like you try it. Sometimes the tissues don't allow for it. So there's lots of venules. It's a very inherent tissue. We have a lot of active surveillance patients in Canada. So the planes aren't always as nice as what we see here, or as you mentioned, the artery. So the high anterior release, I mean, if I can, and there's a nice plane, and I see something's a vein, I'll start a little higher. I find that's sort of the initial flap that you create that will, as well as we know, there are some nerves, the majority of them are going to be along the posterolateral. But if you can get that initial flap, sometimes that'll assist you, sort of a handle for your assistant, continue to allow you to continue that plane and get a less tension perhaps where the dominant nerves are.
Okay. As a result, what we can say, first of all, there are anatomic variations from one person to another one. The prostatic fascia may fuse with the capsule. So we have to arrange our operation